Here we go. Okay. Hello, everybody. My name is Evan Adler, and I'm a physical therapist here at UNC Health. And welcome back to Therapy Thursday. It is the 16th of September, 2021, and we are back from our summer hiatus and getting back to doing what we do best and helping to educate the community on different topics related to physical therapy, yeah, just have a well-informed public and give you information that you can use to better yourselves and let you know how PT can help you. I'm a physical therapist based here at the Northwest Cary Wellness Center, and I'm also the chair of the Community Engagement Committee. And Therapy Thursday is a service of that. And we're really happy to bring this back to you. I am the creator, the curator, and today, not just your host, but also your presenter. So, with all of those hats, I am going to go ahead and start to share my PowerPoint here. And today, we are going to talk about dry needling. What's the point? So we're going to talk about this today, and I'm going to go over a whole bunch of different things. Can you see that? No, you cannot see that yet. Here we go. Ready? Let's try that again. Okay. How about now? Can we see that? Okay, cool. Okay, so okay, dry needling, what's the point? Okay, so before we get started here, if you have any questions as we go along, please drop them into the chat. If it's something that I can answer right away and quickly, I will. If not, we'll kind of hold it to the end. We'll save some time there. And also, since I'm kind of doing double duty here, I am going to put the links to our Facebook page and our YouTube channel in the chat once we get further along. You'll be able to see our channel on YouTube that has all of our Therapy Thursday presentations there with a vast variety of topics that you can explore. But without further ado, let's get into what we're talking about today, dry needling. So first, a little bit about myself. I am a physical therapist. I'm the clinic coordinator here. I'm a board certified orthopedic specialist, certified in several manual techniques, including Graston technique, which is instrument assisted soft tissue mobilization. So if you've seen those kind of metal tools, those scary metal tools in the clinic, that's what those are. And I'm also dry needling certified for levels 1 and 2. Work here at the UNC Wellness Center in Northwest Cary. Runner, cyclist. I've recently got back into tennis and softball, so I'm kind of rounding out my activities. Big music enthusiast, and of course, proud husband and dad of my 2 boys, who you can see there in the pictures. All right, enough of that sappy stuff. So let's talk about what we're going to be doing today. We're going to talk about some terminology so we can kind of get that boring stuff out of the way. Talk about the background of dry needling and kind of where it came from. Big question that I get all the time is what is the difference between dry needling and acupuncture? So we're going to address that. We're going to talk about some symptoms for treatment, what it is, the procedure itself, how it can help, and kind of what some of the risks are and what to expect after treatment. This presentation is a little more geared towards running injuries, just because that's one of my specialties, and I treat a lot of runners with this. But if you have other questions, please feel free to ask as we go along. Okay, so let's talk about this important terminology. Intramuscular manual therapy, or IMT, that's one of the clinical terms for dry needling. IMT, you'll see that in our documentation here. That's the standard abbreviation that we've taken here at UNC. but there are various other names that it goes by, which we'll talk about soon. Myofascial trigger point, so a MTRP, or what we'll just call a trigger point, also goes by a muscle knot. Okay, so when we talk about that, a trigger point or a muscle knot, those terms are interchangeable. It's a hyper-irritable spot in the skeletal muscle that's associated with hypersensitive, palpable nodule in a taut band. So if we just break that down, it is a sensitive bump where it should be smooth. Um, and that's kind of that knot in that soft tissue, right? So you got two types. You have an active trigger point where it hurts all the time. You don't need to be poking on it to know that, okay, I've got this trigger point in my neck and man, it just hurts all the time. And then you have a latent trigger point, which is, oh, my neck feels stiff. Oh, right there, I can feel it right there. And so you get that. That's kind of the difference between those two. Both types can cause stiffness, and that stiffness can cause a loss of range of motion. So looking at the neck, if you have it up here, you may not be able to turn your head as far as you could, or tilt to the side as far as you were before. Okay, so let's do a brief history of dry needling. So kind of the biggest names, the founders of dry needling were Travell and Simons. Dr. Janet Travell was a personal physician for John Kennedy. First female White House physician. So interesting point of trivia. Dr. Simons, he studied kind of and documented the physiology of the trigger points in both the lab and the clinic.
What is going on?
They produced the first comprehensive volume text for physicians regarding trigger points in 1942. We started to introduce this concept of injecting muscle trigger points to the medical community. Okay, so what we would more consider, I guess, like a wet needling versus a dry needling. Okay, actually injecting some sort of substance into the soft tissue to get that trigger point to release. But they helped to really define what myofascial pain was for modern Western medicine. Okay, so you have the self-sustaining characteristic of trigger points depending on a feedback mechanism between the trigger point and the central nervous system. Okay, so it basically, the muscle gets into this loop where, and I think we're going to talk about this soon, but not next. We'll talk about it more. But you basically get into this feedback loop of the muscle in this constant state of contraction and never really being able to release until something is acted upon. So the central nervous system is just giving it juice the whole time without letting it release. We'll talk more about that shortly. In 1979, Carl Lewitt came along and proposed that the effect of injections were primarily caused by the mechanical stimulation of a myofascial trigger point with the needle alone. Okay, so that was a really important step, because now we can go from that wet needling to a dry needling where nothing actually has to be injected into the tissue for that trigger point to release or have that localized twitch response that we're going to be talking about later. So the needle alone was enough to disrupt that energy flow to get things released and moving again. So today, based on these two big studies, we have wider use and application of dry needling with various terminology, all referring to the same practice. So we have intramuscular manual therapy, which is what we were talking about before, IMT, that's our convention here at UNC. Functional dry needling, intramuscular stimulation, trigger point dry needling, or just dry needling itself. It's all the same thing. Same words for, different words for the exact same thing. Okay.
Just a minute.
Here we go. Okay, so let's talk about dry needling versus acupuncture. Let's see here. Just one moment here. Sorry, slight technical difficulty. Okay, I think we're still good. Okay, so dry needling versus acupuncture. So I have dry needling at the top, but let's go down to the bottom first and talk about acupuncture. Now, I don't pretend that I am an acupuncturist and am fully skilled in that practice. But you know, from reading the research, and I can speak to what I know and what the differences are as someone who does dry needling. So the definition of acupuncture is a form of healthcare developed from traditional and modern Chinese medical concepts. So an Eastern medicine concept of employing an acupuncture diagnosis and treatment for the promotion, maintenance, restoration of health, and the prevention of disease. Okay, so the practice is what's more important here. So they use a acupuncture needle and the application of moxibustion, which I love that word, very cool word. So that's the circulation of nutrients and substances and energy called qi through a network of meridians along the body. Okay, so based on an acupuncture diagram, where you may be having pain in your shoulder, you may be getting needles in your feet or in your head to address that part of your body. That is the part that I am not very skilled in knowing all that information. What I can tell you is that the main difference is that dry needling is a skilled intervention using a thin filiform needle, which, to be perfectly honest, is exactly the same as an acupuncture needle. They are the same exact needles, but they penetrate the skin and stimulate underlying myofascial trigger points, muscular and connective tissues for the management of neuromuscular pain and movement impairments. So what we are doing is we are applying that a Western, probably the most Western style of medicine to an Eastern concept. So instead of trying to align your chi, we are taking this needle and we are putting it directly into that trigger point that hurts. And we are trying to elicit this localized twitch response to get that kind of balled up tissue to overcontract and then relax. Okay, and again, we're going to talk about more of that in a moment. Okay, so here's some of the benefits of dry needling. Now, the effectiveness of dry needling is dependent on the skill of the practitioner. Okay, so this is a very specific treatment. Like we said, we're not putting needles in various parts of the body to affect things in other places. We are looking for that exact trigger point to put the needle right into it. So a very advanced, skilled knowledge of the body's anatomy, the directions of the fibers in which they run, the depth of the tissue that you're looking to hit, making sure we're avoiding major neurovascular structures. All of that plays into the skill of the practitioner and how effective they are going to be in their treatment. So it's useful in improving pain control, reducing muscular tension, normalizing biomechanical and electrical dysfunction of motor end plates, and facilitating an accelerated return to active rehabilitation. So we are trying to get that tightened band of tissue to give it this kind of Kickstarter, hit that reset button for things to relax so we can return back to a more optimal length for that tissue to regain your range of motion and to regain your function. So various studies as of late have shown tremendous improvement with all sorts of different pathologies, including knee OA and hip OA, osteoarthritis, piriformis syndrome, so that kind of tightness in that back pocket and that radiating kind of sciatica down the back of the leg, carpal tunnel syndrome, headaches, TMJ, so chronic jaw pain, acute jaw pain, shoulder pain, neck pain, back pain, even plantar fasciitis, which I've talked about before in other talks and certainly to runners before. All of these can be helped with the addition of dry needling to a comprehensive treatment plan. So as I was saying before, we're trying to elicit a local twitch response, giving a strong neural impulse to that myofascial trigger point circuit to break the cycle. And again, we're going to talk about it in a moment, a little more specifically, but we're trying to break that electrical cycle of continuing to have that muscle to fire, interrupt that cycle so that it will release. So it's useful not only on active, but also latent trigger points. Okay? Release of latent trigger points allow muscle to really get that optimal length. Okay, here's where it gets just a little heady for a moment. So let's talk. We're just going to talk physiologically about the mechanism of this trigger point. Okay, at the motor end plate, kind of where this energy is being fed to the muscle. Okay, with a trigger point, you're getting this abnormality at the end plate. Okay, there's an increased acetylcholine release, which is kind of feeding this contraction of the muscle. You also have this sustained calcium release, which also is telling the muscle to continue to contract. Okay, as you're doing that, you get a local ischemia from compression of the capillaries. Okay, so ischemia is you are basically squeezing out all the opportunities for oxygen, fresh oxygenated blood to get into that muscle. So now it's kind of just locking down on there, not allowing fresh oxygenated blood to get in there. It's increasing the metabolism around there, so it's getting fed, and just the area in itself is getting fatigued, and there's just an increased energy demand where there's a decreased energy supply now. So now you're going into this this energy crisis, and that's why things just kind of knot up and just lock down. And that's what we're really trying to interrupt, that flow. Okay. So we had a question in there of how is this different from massage? So that's a great question. So there are different styles of massage. Trying to massage works in a more I really want to say in a slower method. Okay, so going from pressure from the outer level down into the muscular tissue can certainly provide a release of that tissue. Trying to create some of that ischemic compression around that trigger point to get it to kind of reset. The difference is that with dry needling, you are actually penetrating the skin into the muscle. You're going into the skin, into the muscle, to put a physical barrier to trigger that release. So it's very quick. It's very quick and very effective. Can this work on folks that are needle phobic? I'm going to table that question for a moment because we're going to talk about some of the contraindications, and that is the number one contraindication. So hold that thought. I'll get there. Okay, so the procedure itself. These needles are tiny. Okay, so I have that graphic there on the side. A matchstick is about 42 millimeters. An acupuncture needle or dry needling needle is the average one that we use here is about 0.25 to 0.3 millimeters. Okay, that's about a quarter the size of a sewing needle. Okay, so it is a super tiny needle. Lengthwise, you're talking about 30 to 100 millimeters. So you can kind of see here, that is the one of the shorter ones. That's a 30 millimeter. So kind of put it in my hand there for reference. Okay, very short needle. This is something that would be looking very superficial. So if I were doing kind of like for TMJ, if I were working on kind of the masseter or temporalis up here, where it's very, very close to the skin, use a very short needle. We only need to go as far as we need to. If I were working on someone's gluteal muscles, kind of in that back quarter, a lot of adipose, a lot of muscle, we're going to use a much longer needle because we need to get to the deeper structures. Okay, so indications for dry needling. Muscle pain as a main complaint. So one of the big things that we do is try to discern where that pain is coming from. Is it a muscle? Is it a joint? Is it tendinous? Is it bone? And we have certain ways that we go about kind of figuring those out. But once we boil that down, it's like, okay, you know what? It only hurts when I actually move the muscle, and that's okay. That gets it right there. It's like, okay, that's really a muscle pain. It's a soreness. It's a dull pain. We can definitely work with that. So if there's a really good localization of the pain, so if a patient comes in and says, I'm having neck pain and it's right here. And we get that all the time, like right, a nice trigger point in the upper traps for neck pain or headaches. And we're like, okay, is that your pain? And they say, yes, fantastic. They may be a really good candidate for dry needling. If there's hypomobility in the soft tissue, so can we find a knot in that rope? Is there a knot in that tissue where it doesn't allow you to move as best as we can? And we test that with muscle length and activation tests in clinic. Are there adhesions in the skeletal muscle? So if there's been a healed sprain or strain or after a tear, you're going to have this scar tissue in there, which is going to hold things up a little bit. We can discern if it's really scar tissue or if it's muscle knot around that, and how to address that. Very, very common with overuse injuries, microtraumas, tendinopathies. I always say running is just always an overuse of everything. It's a repetitive motion, and depending on how long you run, distance or time, you are overusing. So microtraumas, tendinopathies has to do with your posture, your positioning, your repetitive motions, or high stress within those motions. Okay. So kind of circling back to that question about contraindications and needle phobia. So the number one contraindication that I find is needle phobia. If you are afraid of needles, I am not going to put a needle in you. It's that simple. Someone comes in who doesn't like needles, the added stress and anxiety of me trying to pitch them on dry needling and actually use the dry needling on them may be completely counteractive to what we're actually trying to do. So someone comes in and says, you know what, I don't like needles. I'm like, okay, we've got other ways to do it. I got my hands I can use. I've got instrument assisted stuff. We can do a litany of other things. Currently, contraindications include pregnancy. They've found that some needling techniques in certain muscles can cause contractions. I mean, that's essentially what we're trying to do, is cause an involuntary contraction of muscle by introducing the needle. So just for complete safety, if you are pregnant, then we defer to other techniques. Now, if it's an early kind of first trimester type thing, that's okay. we found that if it's so early that you may not even know that you're pregnant yet, it's certainly not going to not going to harm anything that early on. But as certainly as it goes on further, we try to shy away from it. Infection, cancers, active systemic inflammatory conditions, anything that we don't want anything that's already inflamed to be even more inflamed from the introduction of a needle. And then certainly uncontrolled bleeding disorders or use of anticoagulants. Because we are piercing the skin, we are going to cause a potential for bleeding. So we don't want to, we just don't want to dip into that unless really a physician has explicitly approved that kind of treatment. All right, and then on the right hand side there's just a bunch of other stuff that are kind of yellow flags as we go along as well, but the big ones are on the left there. Okay, so the technique itself. So with the needle placement, first thing I'm going to do is I'm going to wash my hands, and then I'm going to put on gloves. This is it's a clean technique as opposed to a sterile technique. So we're not in a sterile room, completely sterile environment. But the needles are prepackaged and sterile. So as soon as it's kind of opened up, it stays within a plastic tube. We'll talk about that in a moment here. But I just want to make sure that I am as clean as possible before starting. So I'm going to wipe down the patient's skin with an alcohol swab. I'm going to take the needle out of the packaging. And at that point, I'm going to identify where that trigger point is and stabilize it. I want to kind of roll over it if I can find it. And I want to identify it very specifically because I'm going to go right into it. And then I'm going to put the needle or within the tube directly on that target region. Okay, so now comes the application. So I'm going to do a little bit of a pop of the needle into the skin, just so it'll break the skin a little bit. Pull off the tube, and then the needle goes into the depth of the target muscle. I'm going to make sure that the patient is doing okay at this point. I want to make sure that no one's having any induced phobias or any pain that isn't expected. Okay, so we're going to talk in a moment about what we expect. I don't want any lightning bolts shooting down your leg or down your arm, right? Anything you feel should be pretty localized to where that needle goes. Then I'm going to do a little bit of a pistoning technique. So I'm going to take the needle and it's going to go in and out of that muscle to just kind of fenestrate that tissue, kind of create these little tiny holes, little trigger point, little triggers in there to try to get that that muscle to twitch. So my new favorite expression is tolerable discomfort. That's what I expect patients to feel at this point. Tolerable discomfort. Putting a needle in you is not going to feel great. We know that, but it should also not feel so violently painful to try to get this trigger point to release. That's not what we're looking for. We're looking for an intensity that's going to be quick but tolerable as we do it. How many needles? So there are some therapists who will use many needles all around, and they use a slightly different method of application. Less pistoning and more just kind of letting the needles sit within the muscle bellies. On a first visit, I don't like to use more than 2 or 3 needles for a patient. Just enough so they can get the experience, hopefully get the desired response, and kind of set them up for future visits, following everything up with exercise. So what to expect during and post? We're looking for that trigger point to release, to get that localized twitch response, right? So if you've ever had electrical stimulation, where they turn it up to the point where you have a contraction of the muscle where you are not actually contracting your muscle. That's what we're looking for, but it's supposed to be very quick and it's going to release just as quickly. We're looking for a reduction in pain, increased mobility, or stability in motor control after the treatment. You should have some increased function almost immediately. Now, this is a type of manual therapy. So I absolutely expect there to be short-term benefits, okay, from immediately to up to 4 to 12 weeks, okay? But usually we're going to find about 3 days you're going to have this positive effect if you don't do anything else to help yourself afterwards. That's why it's so important to add therapeutic exercise to compound on the positive effects that you get from dry needling. So I have folks who come in here and they, we sometimes refer to them as needle junkies. They want to come in, they want to get dry needled, they want to be out the door. That's okay, but I'm not going to let you leave without making sure that you know what exercises you need to do. And I'm going to make you do a few of them before you leave because that's going to only help the end goal for our treatment. So there are risks, okay? So we're talking about using a needle, so there are risks involved. Soreness, that's what's going to happen. That's what we're looking for. That's what we want. We want muscle soreness. It should feel like you just had a good workout at the gym, only you're getting that delayed onset muscle soreness immediately. So it's not delayed. So instead of DOMS, you're getting OMS. You may actually have a little bit of minor bleeding from the surface, from the pinhead. It happens. If that happens, I usually just roll some gauze onto it and it clots and you're done. No problem. Bruising can happen as we're going through some of the capillaries there. It happens from time to time. Even the most skilled needlers do that. And that's okay. It goes away within a couple of days. A less common risk that we look at is a pneumothorax. So that's an actual kind of piercing of the lung tissue. So you only have to worry about that if you are needling over the lung field, so anywhere kind of over the thorax. And again, with a clinician who is trained, we know what to look for as far as making sure that we get a bony block so we don't go into the tissue, or we go parallel to the lung field instead of perpendicular to it. So we don't want to pierce any of that lung tissue. That is certainly not a goal, and we do very, very, very good job at not hitting it. Okay, so what if you hit a nerve? Okay, I think I saw a question in the chat pop up before about what if there's too much pain. So if you hit a nerve, you are going to feel kind of one of those kind of lightning bolt sensations where it goes all the way down your leg or all the way out the arm, depending on where you're putting the needle. Okay, if you hit the nerve, if I were to hit the nerve, the patient would tell me what they're feeling. I take the needle out, and basically you're going to have a little bit of soreness there, but it's not going to do any sort of permanent damage whatsoever. The needle has a nice plow effect when it goes in, so that as it goes in, it kind of pushes a lot of those neurovascular structures your veins, your nerves. It kind of just pushes them out of the way as it gets to the muscle where it's actually able to go in. Those other tissues have kind of a sheath around them that allows that muscle to just kind of weave its way into where it's supposed to go. If you hit an artery or a vein, which we take very good caution not to hit an artery, it'll cause a little bit of bruising, but it's usually just a little bit of a pin prick and will clot very soon. If not, for those who have bleeding disorders, that's kind of why we screen those out to begin with. If the needle breaks, so nobody told me this during our course, but I found out from colleagues later on when they asked me, it's like, oh, what happens if the needle breaks? What are you going to do? And I'm like, oh, I don't know. What am I going to do? So usually just by putting another needle in right next to it gets to make it contract, and it's really easy to kind of just pull the other needle out. So never had that happen, and hopefully today's not that day. Okay, the after effects. So a colleague of mine likes to talk about the 4 Ws. So water, stay hydrated. We just released a lot of uh, hydrogen ions and lactic acid into the bloodstream. So let's kind of flush all that stuff out of there, right? So stay hydrated, drink water. 2, walk. So especially for lower extremities. If it's upper extremities, I just want you to move around, right? Just make sure you're not a couch potato the rest of the day. Okay, the third one is warmth. If you're having a lot of soreness afterwards and require, some sort of treatment to make it feel better, I always lean towards warmth over ice. So the third W would be apply some heat or some warmth. That fourth W is an unofficial W. And it said that if you maybe have a glass of wine later that night, it'll kind of cool things out a little bit as well and decrease some of that soreness. Okay, so at this time, I'm going to open it up for some questions. Let me do this here. Oops. I'm going to leave that up, but I want to take a look at the chat because I think I missed a couple. Um, Chat. Here we go. Okay, so we talked about the needle phobic. How long does the process take? So the needling itself is very quick. It's a poke and a stick, a piston, and done. The setup and the education is what takes a little bit longer. So if it were part of your session, I would expect maybe 20 minutes of education setup, and then the actual needling maybe takes 5 total, depending on how many needles you're using. If you get such a reaction that it requires longer, then we just let the needles stay in there, and I like to say we just let it marinate and let it just kind of hang out there, and the muscle will kind of grab at the needles. Let it grab until it stops grabbing, and then we remove the needle. What happens if there's too much pain? We stop. If there's pain, no more needles. Okay? Tolerable discomfort. That's what it should be. It should never be so much pain that we're causing more trauma to the patient than they came in with. All right? This is supposed to be a therapeutic intervention. Does it require more than one time? So I would say yes, usually it does. Sometimes it's quick. It can be, one isolated incident. Give it a little treatment and follow it up with some exercise, and they're good to go. But a lot of patients come in with more chronic issues, and needling becomes just part of the overall treatment plan. Can end up doing, 6 to 8 sessions. All depends on the patient. How long is the training for a practitioner? So it is a continuing education course. The level, let's see, so the first level of each level of dry needling is a 32-hour course. So it's a 3-day course all day long, where we pair up during the course and use each other as pin cushions for the entire day. There's usually a lot of that unofficial W that night, as we are all very sore. However, I take pride in the fact of knowing that I'm not needling anybody in any place that I haven't been needled myself. So I know what you're going to feel when I do it. I know what it's supposed to feel like. I also know what it's not supposed to feel like. I've had needling done before where it has not been successful, and it's been in the wrong place and it's hit a nerve. And I know that's not comfortable. Um, so, um, so that's a long way of saying it is a very long 3-day weekend. And yep, so that's that question there. Okay. Anybody have any other questions at this time? Oh wow, we have way more people on here than I thought we did when we started. That's cool. Hey, hi everybody. Awesome. So, let's see here. So while you're thinking about questions, so we still have about another 5 minutes here before I'm gonna let everybody go, but I'm gonna go ahead and copy and paste into the chat here. This is our Facebook page and our YouTube channel. I would really encourage you to go check it out. Check our YouTube channel out there. Sorry for that long URL, but we still need enough subscribers to get a better name. So please subscribe to our YouTube channel and I can get you a much shorter URL. Um, so, uh, so yeah, so there's lots of great information on there. You can also check out our Facebook page to find out about more Therapy Thursday events and where we are going to be in the future. Okay, so there was a question that came through. Would you do this on a posterior tib tendinopathy? And absolutely. Yes, the posterior tib is a very common muscle that we use. That is found in the calf for those of you who are not familiar. And that muscle is very instrumental for runners. We see that a lot, kind of doing that plantar flexion, pointing the toes, and then kind of bringing the foot towards the inside. That's a big muscle that we do needling on to help release. Absolutely. Do you need a medical background or a license to do the education? Yes, you absolutely do. I have seen, let's see, the courses that I've taken, obviously physical therapists. There was a chiropractor in one of the courses. There was a podiatrist in one of the courses. But yes, unfortunately, not anybody off the street can take it. You do have to have some sort of prerequisite medical background. I don't. I don't think athletic trainers can. I'm not sure about that. I'm not going to wager a guess on that. But yes, you do need some sort of medical training prior to taking that course. Yes. Okay. Oh, I did miss one here that said that, let's see. Yeah, Julie said that she's had dry needling a few times and would definitely do it again, provided great relief. That's excellent. That's great to hear. I've had issues myself with neck pain, low back pain, hip pain, foot pain. Man, I'm getting old. Okay, so I've had lots of stuff needled, and it is intense, but it can really help, especially in the very short interim, right? I do a lot of work with my hands. I do a lot of manual therapy. So I often get cramping and tightness right here in my thumb. And this is a very, very easily needled and responsive place for dry needling. And it's actually something that I can needle myself if I don't think about it too much before I do it. So yeah, it can be of great help if you have questions and think that dry needling might be a good option for you. Please reach out. Let me know. I'd be happy to talk to you more about it. I'm just trying to. That's not working. Okay. Just trying to find my. My contact information is not working. Anyway, so I'm gonna just type my email address here. You can feel free to email me directly if you have questions. There's a question, is this usually covered by insurance? Absolutely it is. Not only is it covered by insurance, but there is no separate charge for it at all. It is considered to be part of manual therapy. So when you see the billing from us, what happens is that we bill for the education, the setup, the identification of the trigger point and the pathology. We do not bill for the actual needling itself. Okay, so it's a fine line, but in the state of North Carolina, that's how it is billed. There is no extra charge for it at all. It's just it would be, if you had a copay, it would be covered under your copay. Okay. Excellent. All right. Well, we'll give you one more minute there to put in any other any questions. But while you're thinking of those, I want to thank everybody for joining my talk today. I really appreciate you coming out. This will be posted on our YouTube page by the end of the day today. So I encourage you to go ahead and watch it again. My jokes only get better the second time around. And yeah, please do subscribe to our channel. Let me know if you have any questions. It was a pleasure to talk with all of you today. And I don't think we have any other questions there. So thank you all. I appreciate you coming today. And yeah, we'll see you at the next Therapy Thursday. All right, thanks all.
Thank you.